In this high topic, we are going to learn about alpha-1 antitrypsin deficiency. So the first thing we have to know about alpha-1 antitrypsin is that it sits on chromosome 40. And the expression, the genetic expression is codominant expression. What do I mean by codominant expression? We know that every chromosome, one allele we get from father, one allele we get from mother. Okay. And one of these alleles is deactivated. But in codominant expression, both the alleles, one which is got from father, one which is got from mother, both express themselves. And this results into three different type of genotype and phenotype. So the first and the most common or the wild type is PIMM. What do I mean by PIMM? This is the wild type or the normal type. Then we have got PIMZ. PIMZ means one of the allele which is received either from the father or the mother is defective. In this case, almost 60% of the enzyme activity is preserved of alpha-1 antitrypsin, and this causes minor disease. The most severe variety is PIZ when both the alleles, both from father and the mother, is received and both are defective. In that case, less than 10% of the enzyme activity is there, and this causes severe disease. So when we talk about primarily clinical alpha-1 antitrypsin deficiency, it is this genotype and phenotype we are talking about. So again, alpha-1 antitrypsin, it is found on chromosome 14 with a codominant expression, and this has been asked in examination. Let's look at pathogenesis. How does alpha-1 antitrypsin deficiency manifest itself? Now here, one thing I want to tell you is that there is not decreased production, but there is a protein folding defect because of the defective gene. The defective allele produces a enzyme which is not folded properly, and hence there is a dysfunctional enzyme production and decrease in the functional enzyme. And both of these, so on one hand, we have a malfolded or a not normally folded protein, and the accumulation will cause some effect. And on one hand, the functional alpha-1 antitrypsin is deficient, that will cause some clinical features. So let's look at each one by one. Before that, let's look at what is the function of alpha-1 antitrypsin. So alpha-1 antitrypsin basically inhibits proteases. And these proteases, especially three proteases, elastase, cathepsin G, and proteinase 3, all these three proteases are produced by neutrophils, and they're very important for anti-inflammatory, action on the inflammatory side. So what will happen if there is a deficiency of alpha-1 antitrypsin? So alpha-1 antitrypsin deficiency will cause uncontrolled action of these proteases. Okay, so they will be increased in the activity of elastase, and this will lead to the damage of the elastase. Okay, so that is the one of the mechanism. The second mechanism is accumulation of the misfolded protein. That will get accumulated in the hepatocytes, and this will lead to hepatitis, cirrhosis, and ultimately it may even cause hepatocellular carcinoma. So there are two different set of clinical symptoms which I am seeing. One, because of the overactivity of elastase, cathepsin G, and proteinase 3, which will lead to destruction of the elastin tissue, especially in the lung, causing severe emphysema or earlier COPD. And the second set of manifestation is where this misfolded protein is accumulated in the liver, and that will lead to hepatitis, cirrhosis, and hepatocellular carcinoma. Having said that, let's quickly learn about the clinical features. So interestingly, it many times manifests even in the neonatal period. In fact, it is one of the most common history which we get. So in neonatal period, it presents as neonatal jaundice, okay, especially as cholestatic jaundice. Okay, and generally after the neonatal period, the person may not have any symptom until middle age, where again he will have liver failure. He will present with liver failure primarily due to the constant liver injury, hepatitis, cirrhosis, and even in 2 to 3% of the cases, it may even progress to hepatocellular carcinoma. So one of the etiological factors of hepatocellular carcinoma, remember, it will be alpha-1 antitrypsin deficiency. In lungs, we have said that in childhood or you will have a history of recurrent lung infection. There will be severe emphysema and early COPD. So any patient who is having very early COPD, you might think of alpha-1 antitrypsin deficiency. Less commonly, it can also have some skin manifestation like paniculitis, which is nothing but inflammation of subcutaneous fat, which leads to tender macules or papules on, especially on the legs and all. So these are the clinical features. How do we diagnose? Diagnosis is simple. You can measure serum AAT level, which will be decreased. complete lung examination evaluation will be required for evaluation and management of emphysema and COPD. So tests like chest X-ray, PFT, CT chest, all need to be done. Even liver evaluation, LFT, liver biopsy may be done. Now, in one of the exam question, liver biopsy findings was mentioned. So what are the liver biopsy findings? So this ATT is basically a glycoprotein. Okay, basically a glycoprotein. Okay, so it will be pass positive. The carbohydrate part of this antitrypsin, anti-1 alpha trypsin, that will be pass positive. And so one of the common pass positive molecules in liver is glycogen. But remember, glycogen can be digested by diastase. But this inclusion is diastase resistant. So this molecule alpha 1 antitrypsin will not be dissolved by diastase, unlike glycogen. So pass positive diastase resistance globule in periphery of hepatic lobule. So this is a biopsy finding which you get in alpha 1 antitrypsin deficiency patients. How do we manage it? So one is obviously there will be a lot of recurrent infections. So vaccination becomes very, very important, especially of respiratory pathogens like influenza and pneumococcus. Also, if you see, there's a lot of lung damage because of over activity of elastin. So if the person is smoking, stoppage of smoking, cessation of smoking, or avoidance of smoking will be a very, very important part, because then the destruction of the lung will be delayed. Also, management of COPD, emphysema, liver failure as per the clinical status of the patient, and eventually the patient may require lung or orthoptic liver transplant. So this completes our complete discussion on alpha 1 antitrypsin deficiency. It's a very short topic, but very frequently you will find questions from that. What are the primary questions you will ask? You will be asked about which chromosome, the kind of inheritance, pathogenesis, clinical features, and the diagnosis, that is serum ATT level decrease. You can also go for a genotypic and a genotypic study, gene analysis, that also can be done. So this completes our discussion, and these high-yield topic videos which I'm creating, these are just 3 to 5 minutes video which can help you brush all your high-yield topics in very, very less time and makes it very interesting for you to revise. Thank you.